Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hi, I'm Mark Lebwohl. I'm Dean for Clinical Therapeutics at the Icahn School of Medicine at Mount Sinai and Chairman Emeritus of the Department of Dermatology. And I am joined by my two illustrious colleagues, Alice Gottlieb and Philip Meese, also world experts in psoriasis and psoriatic arthritis. And I'm going to speak to you today about patient-centered care and incorporating patient-reported outcomes. Okay, so there are a number of major issues with psoriasis and psoriatic arthritis that impact quality of life, economic burdens that we don't always think of, and result in very valuable patient-reported outcomes for us. In quality of life, I don't have to tell you that if a person is covered head to toe with psoriasis and can't use their hands or can't walk because of their psoriatic arthritis, that will have a profound impact on personal relationships, on work, on social interactions. In terms of economic burden, it is perhaps a little more apparent with psoriatic arthritis than with psoriasis because patients can't do certain activities, which limits their economic productivity. But even in psoriasis, we have something that we call absenteeism or presenteeism. And presenteeism means they're at work, but they can't concentrate on their work. They can't get their job done as well. And so there is even a financial toll there. And so stress profoundly affects economic burden. And last but not least, we do have some excellent patient-reported outcomes regarding psoriasis and psoriatic arthritis that we will talk about. So here are 6 domains of the disease, and certainly you've heard it, that psoriatic arthritis can precede skin disease. I think the number was about 19% of the time in Dr. Meese's excellent presentation. But indeed, eventually, patients develop skin lesions of psoriasis. So the number here is 100%. Peripheral arthritis occurs in almost 100%, 96% of subjects. Enthesitis in 30 to 50%. Dactylitis in 40 to 50%. Axial disease in 50%. And nail pitting when patients have psoriatic arthritis in 87%. When patients just have psoriasis, nail involvement is common, but not this common. So that is indeed a risk factor for psoriatic arthritis. So we are fortunate to have Phil Meese here, who was one of the founding members of GRAPPA, and I believe the first head of GRAPPA. So I'm going to ask Phil to discuss briefly the GRAPPA goals of therapy.
Well, as we are now targeting or trying to get our patients into, as stated here, the lowest possible level of disease activity. So trying not to have any swollen joints, minimal, if any, skin disease, and so on. To then get this patient to a state where they can function either normally, as they normally would have in their life, or nearly so, and to try to avoid safety issues that might arise, such as increased rates of infection.
Okay. So we have a number of patient-reported outcomes and that look at the aspect of disease and pain in particular. To start with, we have a visual analog scale. Then there are different assessment tools that you see here. Some of them are less widely used, some of them more widely used. Patient global assessments of their own severity of disease with skin and joints. There's a tool or several tools that look at health-related quality of life. And let me ask Alice and then Phil, do you actually use these in your clinical practice, or are they research tools? What is most practical for you to use in the office, and what do you use as a research tool?
So I'm going to actually talk about this in my presentation, that for the dermatologist, in a way, the less work they have to diagnose psoriatic arthritis and measure outcomes, the better. And we have used in the Mount Sinai EMR that we have put the PEST in as a diagnosis instrument, and the PsO, which is a symptoms and a impact 12 questionnaire into the medical record. And we are able to demonstrate that not only can we diagnose psoriatic arthritis, but we can treat to target using the PsO in the context of a dermatology practice. We can increase referrals to rheumatology, and all this work is being done by the patient, not the doctor. We have made it a rheumatologist to click away, and we have, in a way, encouraged strongly the dermatologist to ask about psoriatic arthritis.
Okay. And Phil, what do you do in your practice and in your clinical research?
So in practice, I will admit that it's too burdensome to try to go through all of these types of measurements. But in our clinical research, including contribution of patients to long-term registries, we do. So we do a full 68, 66 joint count. We do enthesitis assessment. We do a skin assessment, usually just a body surface area evaluation. These metrics end up being important for a couple of reasons. One is we now are trying to quantify our ability to treat to a state of remission or low disease activity, and to do so, we need some of these metrics. And the other reason is patients really appreciate it. They, as you can imagine, in Seattle, we have a number of patients that are working in the tech sector, and they come in with their spreadsheets. Have I gotten to minimal disease activity yet or not? And if not, then they're a little bit miffed and want to know how to tweak things to get there. And so I think patients really appreciate your attention to, even if you're not writing down an actual number for body surface area, the fact that you're looking at their skin, looking in their scalp, the fact that you're feeling their enthesial insertion sites, that increases their trust in you as being a comprehensive doctor.
Okay, agree. I will say also some of the scores here that we don't automatically think about, we should. For example, the FACIT score, the fatigue score that's listed. Patients could come in just with profound fatigue because basically the pain and even the chemicals associated with psoriatic arthritis or psoriasis can wipe you out and make you fatigued. So I think something that that these patient-reported outcomes actually help us appreciate better. Now, over here, there are a number of very specific scores, and I think we can repeat what we just said. The scores have very practical uses in a research setting, but most of us won't do a PASI score, for example, which is the most common score when you read the literature and see how well a patient does. We look at PASI 75, meaning a 75% improvement in the Psoriasis Area and Severity Index, which is a measure of skin severity. The NAPSI score is a score for nail psoriasis. Physician's global assessment, which I actually do in clinical practice. In clinical practice, I'll write the body surface area, and I'll write, is the patient 0 to 4, either clear, mild, moderate, severe, or very severe, so that I can then kind of reverse engineer that into a PASI score if I needed to. But there's the LEI as an enthesitis score. Any other scores that you would draw attention to here, Phil?
Well, I think these are not practical for most clinicians to do, but I think it's important for, as you say, as they read the literature, to understand that we now have verified, codified metrics to evaluate clinical response. And this is a way in which we can compare one drug to another, one mechanism of action to another, and give a sense to the treating clinician what works well and what doesn't work so well, and that we are treating the patients comprehensively.
And I'd like to point out again that the PSET is done by the patient, not by the doctor. It is a treat
Right.
to target outcomes, symptoms, and impact instrument with a specific target. And if people download the GRAPPA app, it's even calculated for them. And it's something that the patient does, not the doctor. And I think it's very useful. We do it with all our patients who have psoriatic arthritis.
Okay. So on the next slide, we have yet another list of practical applications. And I'll point out again, we don't do these in our clinical practice, but as research tools, they're very valuable. There are ones that are specific, for example, the joints, the ACR 20, 50, and 70. There are ones specific for skin that I mentioned earlier, the PASI score. Then there are composite scores like minimal disease activity, which looks at both joint scores and skin scores. I actually, when I take care of patients, prefer to have the individual signs and symptoms, because it tells me whether to use a drug that might be a little more effective for arthritis versus one that might be a little more effective for skin. But the composite is a very valuable tool to see overall how happy the patient is. And I will say that many of our colleagues want a drug that simply has an overall benefit for joints and skin. And in fact, I'll go to meetings and people say, well, what's the one drug you would use? So for certain individuals, that would be a reasonable thing to look at. However, I do prefer to taper the particular drug that I use to the patient's signs and symptoms. Any comments about that, Alice and Phil?
Well, in general, I feel the same as you. I think that if somebody has a risk factor for psoriatic arthritis or has any symptoms of psoriatic arthritis, that's going to guide me in one direction, as opposed to patients who have absolutely no risk factors and have no joint pain whatsoever. They're going to have a different set of choices with some overlap.
Okay.
Agreed. And also they're weaving in again the safety features. So we have to think about and ask about, does the patient have underlying abdominal distress and diarrhea? And they don't even think to bring that up in your evaluation of them. You have to ask about that. And so in that particular instance, does the patient have inflammatory bowel disease? And therefore, we're going to use a medicine that not only works in psoriasis and psoriatic arthritis, but also IBD.
Agree. So let's go on to a sample case that brings in many features that might come up. So here is our patient, and the information we have is that she's 28 years old, female, and has persistent skin irritation and scaling. So she comes in, and we want to take a medical history, other history assessments, personal treatment plan. So let's go first to the medical history. 28-year-old female, persistent skin irritation, scaling. She does not have any prior major health issues. To your point about inflammatory bowel disease, Phil, it looks like that's not here. And she's a non-smoker. She presents with dry, thick scale, raised patches and plaques, predominantly on the elbows and scalp, and her symptoms persist for several months before seeking care. So let me ask both of you, I think we would all know what's missing here.
Whether they have psoriatic arthritis or
Yeah.
not. I don't know how you do a treatment for psoriasis if you don't know if they have PsA.
Right.
Because somebody can have a little ditzel on the scalp and they still can have deforming psoriatic arthritis.
Right. So I will say, I mean, I think if you don't learn anything else from this, every time a psoriasis patient comes in, you should ask about joint pain, because they may start out with skin and develop joint pain, or they may present with both at the same time. Rarely will they present, not rarely, but 19%, I think Phil showed, they can present with the arthritis and eventually get the skin lesions. But always ask about joint pain.
The other big missing thing is family history.
Right.
the,
That's coming up, though.
okay, I'll be
So
quick.
here we have it. And
And then
indeed, her mother has a history of psoriasis. So you are spot on, Alice. Um, and so on her physical exam, we note silvery white scale, mild joint pain in fingers reported. So now we finally do get a little history of psoriatic arthritis when we examine her. So always worth looking at the patient's joints. I'd say asking about it directs your examination, but I do actually examine the hands of every patient. They don't even have to take anything off for me to see that. So that is easy. Okay. Now, additional history and assessments. So, her it took her 1.6 years and multiple visits to a primary care practitioner to accurately diagnose her condition. She was initially diagnosed with seborrheic dermatitis, which is a common occurrence when it involves the scalp. So it doesn't mean that it's a bad doctor. It just means that, psoriasis early on can look like seborrheic dermatitis, but that led to treatments that didn't work and to prolonged symptoms without the appropriate therapy. When we look at her body surface area, we estimated 9%, indicating moderate disease severity. And interestingly, the first of our systemic medications to be approved for the skin down to 3% body surface area for mild to moderate disease was a Premolast. And coming back from a recent American Academy of Dermatology meeting, it looks like many other drugs are pursuing that indication. There are certainly patients who have a severe impact on their quality of life by having 3 to 10% body surface area involvement. Okay, in terms of diagnostic tools for psoriasis, I'm sure all of us agree that the patient should be examined. I wonder how often you have to biopsy patients to make a diagnosis of psoriasis, Alice or Phil.
Almost never. The times I biopsy is when the treatments that should work in 90% of patients and more than one of them don't work, then I will biopsy to rule
I
out.
agree completely. It is rare for me to have to biopsy to make a diagnosis of psoriasis.
And I lean on you. So
Okay.
I am often humbled by the fact that I can't be sure about it as a rheumatologist. And so it's very important where I live to be teamed up with dermatologists who are what I call medical dermatologists, meaning they're really interested and focused on dealing with the hard issues like is this psoriasis and managing complex skin disease.
And likewise in New York, we have Alice, who's a rheumatologist and dermatologist, and we have a number of many dermatologists in the city have other rheumatologists whom they work closely for patients with psoriatic arthritis. So I'm going to go to the assessments because I will say, as both of you said in your comments, that we don't really do a lot of patient-reported outcomes. The PSAD is a valuable tool. The DLQI is actually quite easy and could be administered to patients without a lot of loss of physician time, but I think many of us don't take the trouble to do that in our offices. Likewise, many of us won't do PASI scoring in our offices, but we get a gestalt, or as I explained earlier, I do a physician's global assessment and a body surface area. Those are two very easy, quick measurements that I can do without spending a lot of office time, where we see so many patients an hour. Now, the impact on the patient is obvious. If you have 9% body surface area, that may seem like it falls into the mild or moderate range, but the impact of that can be severe on a patient. And here it clearly impacted her emotional well-being and her daily life. So we confirm a diagnosis of psoriasis, and because her disease is limited in extent, she started on topical corticosteroids and vitamin D analogs. Not surprising that with 9% body surface area, they didn't work well enough. And we see that her body surface area now increases to 12%. I would make the argument that even if it remained at 9% and she couldn't be cleared and was miserable, we have a justification to start a systemic therapy. So she indeed was started on an IL-23 inhibitor, and then developed joint symptoms with marked joint pain and stiffness 2 to 3 years after her initial psoriasis diagnosis. Her rheumatologic assessment, which included a physical exam, X-rays, and MRI. And I'll ask you, Phil, how often you do those, confirm the diagnosis, and she had CRP and ESR levels. How often do you do that? And I'll ask you, Alice, as well. I'm sure that the average dermatologist does not do any imaging studies or blood work. How would you address that? And Phil, how would you?
So we do obtain at least X-rays of hands and feet oftentimes, and we do so as a, quote, baseline. We want to know, has this patient had enough prolonged disease activity to have caused joint damage, erosions, joint space narrowing? And it's relatively easy to obtain on these films. And then we can reference back to them 2 years from now, 4 years from now, when we're trying to understand how well have our treatments worked. MRI scanning is mainly reserved for evaluation of spine disease. So getting an MRI of the pelvis to look at the sacroiliac joints, and then often the lumbar or cervical spine, depending upon the patient's symptomatology. And don't forget the fact that many of us have ultrasound in our offices and can do a quick assessment using ultrasound, looking for evidence of inflammation to determine whether the patient has active inflammation or not.
So my practice, I'm a dermatologist and a rheumatologist, but I sit in the dermatology department. So I tend to get not only advanced psoriatic arthritis, but I get patients with no diagnosis of psoriatic arthritis. And I use X-rays mainly when I'm not sure of the diagnosis, when I'm not sure whether is it inflammatory osteoarthritis, is it osteoarthritis, and I'll use X-rays for in the peripheral joints for when I'm not sure of the diagnosis clinically. I agree with Phil that I'm very quick to order, if I can get it, a Ferguson view of the MRI for sacroiliitis. And so, but I talk a lot with my patients and I examine them. So psoriatic arthritis can be diagnosed clinically a fairly high percentage of the time. And I use the imaging when I have a problem in diagnosis.
And how often do you check a SED rate or CRP?
Not that often, because in most psoriatic arthritis patients, as anybody who does a psoriatic arthritis clinical trial knows, they're not elevated. And right. So I don't use it so much. But again, in a derm practice, I mean, Phil probably sees all the train wrecks in psoriatic arthritis. And I see a lower percentage of train wrecks, but I see earlier cases. But I don't find SED rate or CRP is terribly helpful in practice because most patients don't have an elevated one.
Right. So I will say, going on here, we're being asked about other assessments like a health assessment questionnaire. It's a very good tool, again, which the patient fills out, which measures fatigue. Measures disability. And so we can, it has certain uses, but the average dermatologist does not do this in the office. The patient global assessment is analogous to the physician global assessment, but we don't have the patient actually do a score. We basically ask them, how do they feel? So many of the things written about here are useful as research tools, but not typically done in the office. So to reevaluate the patient's psoriasis and psoriatic arthritis, the updated treatment, the patient was started on methotrexate. I think many of my colleagues in dermatology have stopped using methotrexate, or certainly using it a lot less. But the patient here was initiated on methotrexate, but then reported that she wants to become pregnant. And of course, methotrexate is unacceptable at that setting. I particularly avoid methotrexate in women with childbearing potential for
Well,
that reason.
Can I point out that, that methotrexate does not work in axial disease? And
Right.
I've had to argue with insurance companies who want to make me do that first for somebody with axial disease. So I think that's an important thing to point out.
Yeah. Yeah.
And too many people model psoriatic arthritis after rheumatoid arthritis. It's a different disease.
So the patient is then switched to an IL-17 blocker, which is very effective for skin and for joints, and hopefully will do well here. In terms of the patient's obesity, diet and exercise are planned for her. We are now using a lot of weight loss drugs, but we're not using them in women planning a pregnancy. But we are using a lot of diet and exercise in those women, but also weight loss drugs in other patients with psoriasis who are obese if they can't get rid of their excess weight with diet and exercise. So we'll emphasize here that the patient needs and has received team-based care from a rheumatologist, dermatologist, and obstetrician. The patient needs long-term management plans, particularly in view of the fact that she has planned a pregnancy. She needs ongoing assessment of skin and joint symptoms and of the therapies that she is receiving, and benefits from patient education. So in conclusion, early diagnosis and use of validated screening tools, which are primarily used in a research setting, but early diagnosis is essential to prevent progression and direct us in the appropriate treatment. Tailored treatment approaches are important, including biologics and small molecules. Effective management of psoriasis and psoriatic arthritis require a comprehensive approach that includes management not only of the patient's skin and joints, but also of their cardiovascular and metabolic disorders. Incorporating patient-reported outcomes is helpful, particularly as research tools, and a multidisciplinary approach is crucial for providing the best care. Thank you again for joining us for this segment on personalized treatment strategies for psoriasis and psoriatic arthritis. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access supplement slides, as well as other topic segments and case scenarios. Thank you very much.